Thank you. So, for those that don't know me, I'm Trish McDermott. I'm a consultant urology nurse.
My name is Becky. I'm the ward manager of the emergency department.
Okay. So this is our presentation on the gold standard management for acute urinary retention for patients presenting to our ED department in Guernsey. We developed this talk for the Nursing Times Awards. And we were shortlisted for 3 categories: for infection control, for continence management, and for the emergency department.
So we presented 3 times.
So we had a short period of time, 15 minutes, and I'd also like to thank Brian O'Connell and Vicky for helping us put this together, because it was quite complicated because we've got some videos in it. So acute urinary retention is a painful condition which requires immediate treatment, and it's responsible for over 30,000 hospital admissions in the UK, and so that equates to about 3 patients per 1,000. So it's important to remember that, because we're presenting this from Guernsey, and Guernsey is a small locality, so our numbers aren't big, so it's just to bear that in mind. So the complications of acute urinary retention are infection, renal failure if it's not managed. So the management of acute urinary retention: when a patient presents to ED department, they need to have a full assessment undertaken. Following this assessment, they need to have the management plan, and this management plan encompasses having a catheter inserted, and this was also the method undertaken in Guernsey.
So usually our practices is that when a patient, there's multiple ways that patients can present to ED in urinary retention. They can self-present, they can be referred by a GP or community nurses, and that is often the case, especially out of hours over weekends, that we are a first port of call. And also they can be brought in or referred any other way, brought in by ambulance. So they're the 3 ways they come in. When patients come to the ED, they undertake a full assessment. We do observations, we do bladder scanning, we ask them their normal history and questions, and we go through a pathway. And then based on that, we would then involve the doctors, who would then put a indwelling catheter in them, and then they would do all the paperwork that then would refer them to the community services. That's when Trish and her team will pick up the referral that we've made.
Okay. So we would get the patients referred to us. We would then contact them by phone to make sure that they were able to manage the catheter, that they were on the right medication. If they had an enlarged prostate, that would be put on an alpha blocker. If they were constipated, that they would have a laxative. If they needed further equipment, then it would involve either a visit from us or the community nurse. They may also have a visit from the community nurse if they need to have support with a catheter in the community. And then they may have the catheter in for 2 to 3 weeks, depending on what the problem was, and then we would undertake a trial without catheter. At that point, if the patient failed the trial without catheter, we as a team would have taught them intermittent catheterisation. And most of the patients turned around to us and said, well, why couldn't I have been taught this at the very beginning? Which made us stop and think as a team, well, why couldn't our patients be taught this at the beginning? Which started our conversations with the link nurse in the ED department, and he floated the idea with the department and with Becky.
We started, just for your information box, I know not all of you are from this type of background. When we talk about indwelling catheters, these are catheters that stay inside the patient, inside the penis, and stay there for a couple of weeks. What we're talking about is short-term catheters that are put in, drain the urine, and then taken out, and then the dispose of, and then carry on. So it's a very different way that we're looking at this. And what we did to begin with, we did a lot of conversations about whether this was something possibly that we can do. There was quite a bit of a negative response from the beginning, as with any change, about how much time this would take, and this is another thing that we would have to do from a nursing point of view. It felt like there'd be more paperwork and more referral process, but actually that wasn't the case so much, and we finally got on board with the support of Trish and her team and a bit of education, really.
So we had a lot of conversations. We developed a pathway which we've got here to show you, and it went backwards and forwards until we fine-tuned it to suit everybody. We worked out how long it would take to teach a patient intermittent catheterisation, and we timed this, and we found that it took about 15 minutes to teach a patient intermittent catheterisation rather than the 30 minutes to putting an indwelling catheter using the numbing gel, the Instilla gel. You would have to wait 5 minutes, putting in the catheter, and the whole process of preparing the patient after the catheter's in so they know how to look after and manage it. So that process took about 30 minutes, whereas the intermittent was 15, because we had an individual who was uncomfortable, they wanted the urine out, so we had a captive audience there for it. And we developed a discharge pack. So in the pack we had enough catheters if the person had to do it 6 times a day, that they had an information leaflet, and they had our contact details, and we had a DVD as well if they needed that. So this is the flow chart that we developed. It's not very clear here, but we've got some if you want to have a look at. So the patient would present an acute urinary retention. A history would be undertaken, which would also involve taking a scan. A urinalysis is when they had some urine. A digital rectal examination if the patient was constipated, that they would have their bloods undertaken. And then following that, it would be identified what was the reason why they were in retention of urine. If it was constipation, then they'd be put on a laxative. If they had an enlarged prostate, that they'd be put on an alpha blocker. If it was post-surgery, then the management of that.
The next stage really is to get the patient on board, because what we've got to remember is that we're not actually doing it for them, they're doing it for themselves. So this does take a bit of understanding and agreement from them to allow us to teach them to be able to do it themselves. The majority of patients, after a bit of explanation and a bit of understanding about what we were asking them to, were in agreement to do this. The small proportion of patients that did not do it, it was usually down to about dexterity and about frailty that did not allow them to be able to do it themselves. So that's where we were at. But again, a lot of it was about their consent and their agreement to do this.
So the next slide is a little video of Faye, and Faye is one of the ED nurses, and this is her experience of teaching patients intermittent catheterisation.
Hi, I'm Faye. I'm one of the staff nurses in A&E. I've been in A&E for 2 years, and before that I was in community for 3.5 years.
Okay, Faye, can you tell me, how did you find the process when we first discussed teaching patients intermittent catheterisation in A&E?
So it's relatively easy. You've got the pathway and the flow chart and everything, and I find the booklets really easy to follow and helpful for a patient. It's generally patients are quite receptive to it. Sometimes there can be a bit of a barrier there sometimes, but once you've talked them through it, they generally they're generally quite receptive to doing it themselves.
Do you find it any more time consuming taking the time to teach a patient intermittent catheterisation than going through the process of putting an indwelling catheter and ensuring that the patient has the knowledge and skills to manage this afterwards?
Not particularly. There's it's in the short term it's a lot easier for us because although you have to although you have to discuss it with them quite at length before the process, after they've got the process sussed, then they're kind of sorted. But with indwelling, obviously you have all the follow-up with having to sort out community nurses and talking them through how to do night bags and things like that. So there's a lot more to an indwelling catheter after you've put that in, rather than just an intermittent.
And what advice would you give another nurse in another A&E department who was considering using intermittent catheterisation as the first line treatment for retention of urine?
I think if you do the research on it and you read about why it's better for the patient, that can kind of convince you that it is a better thing for the patient with regards to infection and reducing admissions to hospital, and it's a lesser strain on other areas of the services as well if they're needing help from community services. And yeah, it's worth a go.
Okay.
It's
Have
not
you-
as hard as you think it's going to be.
Okay, have you had any feedback from any of your patients who you've taught who've gone home doing intermittent catheterisation?
Not that I can recall, but our A&E department, we don't tend to have people coming back for it, so that must be a good thing.
Okay, thank you.
It wasn't all plain sailing. We had some hurdles to overcome. One of the hurdles was engaging the medical staff, because we found at the start they weren't prescribing the alpha blockers and the laxatives. So I spoke to Becky to see how we could overcome this, and I attended their monthly medical meetings to go through the pathway again, the importance of prescribing the medication so that the patients have the optimum chance of passing urine. So we went through this. We also had our consultant urologist. He was very keen and very supportive with the initiative as well. So to date, we've had 21 patients who presented in retention of urine, and again, remember, Guernsey is a small locality, so our numbers aren't big. But out of those, 20% of the patients had an indwelling catheter, and 80% were taught clean intermittent self-catheterisation. So if you thought back to before 2016, this 100% we've had an indwelling catheter in, which would increase the risk of trauma, increase the risk of infection, increase the risk of hospital admissions. We also found that out of these patients, on a follow-up, 13 only had to put the catheter in once in ED, and then after that they were able to pass urine. 8 of them had to do it once a day following, and then 4 had to do it 4 times a day, and these 4 patients went on then to have prostate surgery. But you must remember, all these patients would have had an indwelling catheter, and especially those 13 who actually wouldn't have needed it.
Right. Can you just tell me how you felt when the nurse first discussed putting in the intermittent catheter to relieve your urine in A&E?
Well, I was a little bit frightened at first, but I mean, after I was shown, it was much better, much better.
Do you feel that the procedure was explained adequately enough for you to undertake?
Yes.
And how did the nurse explain to you to do the procedure?
Wash my hands, make sure my hands were clean, and then how to break the packet with the solution inside, and then how to hold your penis, and then gradually slip the little tube inside your penis till the fluid came out. But I was fine after. No problem. I thought it would be really painful, but it wasn't.
Okay.
Yeah.
And how did you feel when the nurse first said that you had to put the catheter in yourself?
A little frightened, but I thought, well, you've got to do it, and that's it. You've got to do it to make yourself feel better in yourself. But after you've done it once, it was quite easy. It was gone.
And did you feel you had the confidence to undertake the procedure when you went home yourself?
Yes. After I'd been shown, I felt much better. Yeah, and I had to do it, and that was it. Yes.
And now, after having the indwelling catheter, which is the catheter with the balloon in the bag, and now doing the intermittent catheter, putting in the catheter yourself, which would you prefer and why?
Or doing it yourself, because it's much quicker, it's easier, and it's finished with. You ain't got that painfulness in your penis with that catheter that's in a bag inside you, which is really painful. But this way, it's fine. It's over within seconds, and it's done with.
And what advice would you give another man who is in retention of urine and needing a catheter in situ?
That is the one that stays inside you?
Yeah.
No, go for the second one. Go for the tube. And once you've done it once or twice, you should have the confidence, and you should be really fine. No problem. I'd go for that one every time.
Great.
Yeah.
Right, thank you.
Welcome.
With not putting indwelling catheters in, we're reducing the risk of CAUTIA, which is catheter-associated urinary infections. And as we can see here, 70 to 80% of catheter-associated infections are as a result of having an indwelling catheter. Using clean intermittent self-catheterisation, we are reducing this risk because we're not having an indwelling catheter in there. And in our study, no patients presented with a catheter-associated infection, which was really good. And no patients in the study required a hospital admission as a result of this. So we were asked for our study to talk about the wow factor. And the wow factor that we felt was that teamwork together, we can deliver a gold standard service. This is the gold standard for the management of acute urinary retention, and working together we're able to deliver this. We're preventing catheter-associated urinary infections because we're not having indwelling long-term catheters in there. And also that it's patient comfort and satisfaction, and this was developed out of patients' feedback and what they actually wanted.
We noticed that after this had been introduced, it is part of our practice now. This is something that's offered to patients as soon as they come in retention. This is our default now, and I think that's been really positive for us. I describe it as a bit of a ripple effect. We got a couple of people who are willing to really champion this and really give it a go, and I think that's the same with any change. And then they then taught the next people and the new people that are coming through. We've actually had just a new consultant started this week, and who thinks this is amazing, and why are other areas and other ED departments not doing it? And I think from our time at the Nursing Time Awards, it was definitely something that no other department is doing. We were questioned by some of the ED high up in the ED and infection control, and they'd never heard it done before. So I think we've shown by our study here that actually it doesn't matter whether we're a small place, we can actually make a difference with change and doing something very proactively and positively. And also with our safety standards and our SCAPE as well, it is actually embedded in our SCAPE standards. There's a huge section on continence, and this now we can demonstrate that we're being proactive about that. So it's all successful as far as we're concerned.
Yeah. And recently our urologist was off on sabbatical, and we had 4 urologists covering them, and that was one of the feedback that they'd given, that we're very proactive in intermittent catheterisation here, and they've brought back our pathways to their areas to see if we can be introduced there.
Thank you very much.
Hello everybody. For those of you who don't know me, I'm Dawn Watson. I'm the risk management midwife up on Loveridge.
And I'm Jo, community maternity support worker.
And we're going to tell you again about how our journey to achieving our blue state status. So, I think has everybody done SCAPE? I know ED have done it. So we all know the huge big document that lands on your desk. So we initially, I'm going to show you that slide first. So that was our initial, so it shows our journey basically, and our initial baseline assessment back in 2015. As you can see, we've got a lot of red on there. And I'm not going to say that our journey to getting all green has been easy. There's been a lot of, sort of when when that document lands on people's desks to do it, a lot of, oh God, not again. But I think seeing all that red in the, sort of in that audit tool was a real eye opener for us, and having that external viewpoint, sort of, like I say, was a real eye opener to to getting us to look beyond what we see every day, because it is that thing of when you work in an environment and you're practicing it every day, you just become unseeing to the things that can be improved, and we can change for the benefit of our staff and for our service users. So we had to get our staff on board, which we have over the thing, and we also looked at getting user engagement as well through our Maternity Voices group. So we've looked at getting their viewpoints as to how we could improve. So as part of my role, obviously, in quality and safety and governance, One of the big things that we looked at as part of the SCAPE audit was our governance process. Our governance process wasn't robust at all, I would say, like sort of safely say, standing here. Sort of our meetings used to be particularly focused around individual incidents. We'd spend a lot of time, we weren't looking at, sort of how we changed processes, sort of how we improved safety. It was just basically around a lot of discussing the incidents. So we've changed that, sort of to look at it in a much better format. We now have a joint quarterly governance meeting between maternity and peds. So we have, each department has a monthly audit, and then we come together once every quarter to discuss things that obviously cross over between the two departments. One of our big points was that people didn't feel like they got feedback from incidents. And in that way people were then reluctant to put in incidents, because it was that, well, I never find out what happens about it anyway, so nobody takes any notice, so what's the point? So we introduced our watch out for notice. We've also introduced a governance newsletter, and we started having monthly, well in fact fortnightly incident meetings, which sort of have changed format over the years, to give that feedback to staff, as well as their obviously getting their feedback from their incident form as well. And I think a big part of, in the last year to 18 months, I think, is trying to erode that feeling of isolation that maternity services has. Sort of that we're, sort of a little island in the hospital that nobody ever comes near. So, sort of we've had, sort of more meetings with ED. We've sort of with the ambulance service. Our sort of definitely our role and involvement with quality and safety has improved over those years. We've participated in Safer Every Day quite frequently over the last couple of years, as well. Sorry, I keep turning around because it's behind me. Compliments and complaints, that's another part of, sort of we don't, certainly in my role, I feel, sort of we're constantly focusing on the things that went wrong, or sort of where we could improve things. So we've started to try and focus more on what we've done right, and then sort of enjoy our successes. So we actively give out the what we are listening forms. We implemented our kind of how are we doing board. So it's just a big blackboard with white sticky tape on it, and we encourage the families to write on that, sort of any comments before they leave or while they're on the ward. And obviously cards and things, and from the governance team, we actively send out all the compliments that come through there to the staff and put it on our governance board as well. That's an awful slide. That was just some of the feedback, that we've received. Sort of everything was brilliant. Lots of thanks. Everything, sort of people were amazing. So. Our other big issue was our recruitment and retention, which I don't think we're in the minority of. I think that's across the board in the organisation. We went from, when we had our extraordinary review, they advised that we increased our staffing, so we went from having 3 midwives on a shift to run the whole department to 4, which also then included a Band 7 coordinator as well, who was then supernumerary to those 4. So we've actually, on a morning, we go up to 5. Back in 2015, we had 11 whole-time equivalent vacancies, and we had a huge number of agency midwives in attempt to fill that hole. Up till 2019, we have now successfully converted 3 of our agency midwives to full-time staff. We're now down to 1, in fact I don't even know, we've got 1 Band 7 vacancy now, so I think we've recruited to that. So we're actually at full staffing. I'm not saying it, touch wood, whether it'll stay like that. So that's really good. We're also looking at, sort of we've created new roles within the team. So we've now got a PDL post, which is actually 2 midwives, they're job sharing that. And we are looking at ways to develop our Band 6s, sort of to give them a leadership program to, sort of, so they have got something that they can see that they can move up for and work to. In ways of improving our retention, we've done a few different things. So we signed up for the Caring for You RCM Charter. That was back a couple of years ago now. We actively celebrate Midwives Day and the Maternity Support Worker Day. Sort of by giving each other little gifts and having little tea parties and sort of doing boards with what everybody's role is, sort of celebrating that. And then our latest development is our welcoming group. So we realised that we were getting quite a few members of staff who were falling off before they even got here because of the length of time it took them from the interview date to actually getting in post. So we've sorted out a little small group of midwives and sort of some of the admin staff and the MSWs, and we get in touch with them as soon as basically they've been given that post, with their permission of course. Keep in touch, find out what's going on, find out a little bit about them. We put up a little info leaflet about sort of their likes and dislikes and a little introduction to them before they even get here. If they want to, we have somebody who comes, goes to the airport or the ferry and meets them off the ferry. We buy them a little gift basket of, sort of essential bits so that when they get to their accommodation, they do have, if they arrive on a Sunday afternoon and they haven't realised that Guernsey shops are all closed and because we've had, with some of our staff, sort of they arrived and accommodation didn't even realise they were coming. They've been given a set of keys and told this is where it is, but nobody's been able to take them to where it was. They didn't know how to get a bus to work the next day, so kind of just tried to improve all those things. And I think we've done it with the last 3 members of staff, and it's it's gone down really well. And actually, those staff have just literally slotted straight into the unit immediately. So, like I said, practice development we've now got in place. So. We've already looked, NIPE, for those of you who are not maternity thing, is the newborn examination. So previously that's always been done by the paediatricians or the GPs, and majority of the GP practices charge our service users for that. So we've now got 4 or 5 midwives in place who can undertake that examination. So that means that it can be done. It has to be done within 72 hours. It's usually done within 24, and so we don't have that families waiting around for the GP to try and come, sort of at the end of their surgery. And that sort of the practice development leads are going to link in with that that progression and development plan for the Band 6s, and I liaise with those so we can pick up themes from incidents, so we can look at where our training needs are. Quality and safety, so we now have dashboards for all of our training, KPIs, all of our delivery rates and things, which is reported in our governance meeting. I still don't know what the blood pressure and pulse thing, where that came from, but we have developed a link with Portsmouth, so a partnership. So basically all of our midwives now have the option to go and work in Portsmouth. They usually go for about 3.5 days. They all come up with their own objectives as to what they want to do with that, and then we assign them obviously midwives or a team to go and work with so that they can achieve those goals, and then they feed back to us when they come back. We used to, years and years ago, have a Tri-Island partnership with the Isle of Man and Jersey, which unfortunately, due to staffing and changes, has kind of fizzled out in the previous years. So we're now trying to improve that and get that going again. So I went over in September and did a reciprocal SCAPE audit in the maternity unit in the Isle of Man, and then they're hopefully going to come over here so that they can look at how we developed, and we can show them some of our improvements, and hopefully we'll be able to do that with Jersey. So not only will we have our internal, external auditors, but hopefully we'll get external from our hospital coming backwards and forwards as well, sharing ideas. Kind of did that, and I shall pass you over to Jo.
Thank you. So traditionally, maternity support workers, when I first started 13 years ago, we were really auxiliaries. We were on a Band 2. We did an awful lot of the basic jobs. We did cleaning, we did stocking. We didn't always have an awful lot of patient contact. There was the level 3 MVQ pathway to follow if anybody wanted to, but it's quite heavy going, and a lot of people were just quite happy doing what they were doing. And that was it. We had no other formal training really. So now, since 2017, all of our new starters start on band 3. They have the care certificate, as throughout the rest of the hospital, needs to be completed within 6 months. But we also have an MSW pathway set up as well, so very much more tailored to maternity, covering the things that we're going to cover in maternity: blood loss, breastfeeding, those kind of things. So they do all that on the ward while they're working, with the midwife's help and other MSWs. They need to be achieved, signed off, and then kind of that's it, and off they go, and they can then be unsupervised. Saying that, we also follow an RCM pathway, which is like a traffic light system. So there's certain things. You have the green that basically, you know, most people can do. Amber is you can do that once you've had your training, once you've done your competencies, and once everyone's happy. And then the red, which is just no, those are definite midwifery jobs, and we don't do them at all. These are our roles and responsibilities. So again, this is very much, you know, driven from the RCM, which is what we're following. And all these things are just a progression of our role that we can now do with our training, that is taking the midwife away from the more maybe mundane things, and they're able to then spend time with high risk patients, with the antenatal patients, people that we don't necessarily need to get involved in. Doing bloods, it, you know, doesn't take long, but then also it's then that 20 minutes of taking a midwife away from a more high risk patient. We're quite capable of taking blood with the correct training, taking blood samples from babies as well, day 5s. We do a little heel prick test, so we can do that too. We do all the observations, removing catheters, and giving the information, the discharge information to mums too, that they might need. We go through all of that as well. So postnatal visiting, this is my role. This is what I do now. And 4 years ago, we didn't have community MSWs. It was midwives only. And again, a lot of them, they were going out. They had a lot of visits. Some of them were really quite basic, maybe some help with breastfeeding, just basic checks, but it was taking up their time. And this is when the link with Portsmouth came in. So I went over to Portsmouth, saw what the community MSWs were doing there, realising what an enormous role they had and how much responsibility. We were like, yeah, we can do this too. So then that's what we started. So I started going out with the midwives, seeing how visits went, how things happened, and that's what I've been doing for the last 4 years. We've also got another couple of MSWs who are doing the same sort of thing. They're spending time on the ward, but then also a couple of days a week out in community to learn that role and to really get that experience. And then, in fact, one of them has just started going out on her own as well. We're all very aware of our limitations. There's always midwives that we can get hold of. Anything that comes up that we're not sure about, there's always someone on the end of the phone, so that's great. Bosom Buddies, this is my little baby as well. So we started a breastfeeding clinic again. We realised that we were spending a lot of time at home with people who perhaps needed a bit of breastfeeding help, but actually they were having to stay in and wait for us to come, and some of it might have been quite basic. So we started this, and it kind of started as more of a clinic. So they came to us if there was a problem, and we would help them. It was only once a week, it was only for an hour. And we realised that actually lots of people were coming, and lots of people were coming just not really with major problems. They just kind of wanted to see us. And also trying, when you've got a new baby, trying to get to a certain time in 1 hour a week was really quite tough. So we made it bigger. We still only do it once a week, but it is for 2 hours now, done at Bright Beginnings at Delancey. And it's kind of really turned into quite a big peer support group as well. So I've just come from there today. We must have had 12 ladies there. I think maybe 4 or 5 actually had some problems and needed us to help. The rest were just sitting having a cup of tea and, you know, having a good old chat. And in fact, those ladies that had the problems, there was one in particular, before I could get to her, there was another mum saying, "Oh, that happened to me as well. It's absolutely awful, isn't it? And oh, I know, you're so exhausted," and things. So she'd kind of already done the groundwork for me before I got there. So, you know, which is amazing. Then because we have that contact with them, if they need any follow-up, so if they're out of our kind of 28 days, we refer to the health visitor, we get in contact with the health visitor and say, actually, I think this mum needs a bit more help. Or if it's within 28 days, then I could follow up with a phone call or an extra visit and see how they're going. We've also, it doesn't say there, but we've also set up a breast pump library as well. So we now have 3 breast pumps that we can loan out to people for 28 days at a time for a small donation. So that's great too. So, you know, they don't have to buy an expensive pump if they just want to try it and see if it works for them or if it's going to help get over a certain issue. Antenatal sessions, again, this is something that the MSWs have really started to get involved in, instead of very much just being on the ward and being in the background. They're using their experience, discussing antenatal sessions with them, and, you know, how to bath your baby and settling and feeding and things like that. And I also do a breastfeeding workshop as well. We do that around about once every 5-6 weeks. So new mums or prospective mums and parents and dads come along, and so we kind of tell them what to expect about breastfeeding before they even get there. And I think that's it. But just to say, like, our role has really kind of like progressed, and I think that's, you know, it's been really great to see that development from where we were before.
And I think that for me is part of our key message, is that you know, sort of implementing SCAPE in maternity wasn't, you know, sort of, yeah, it might have started with the management saying this is what we need to do, but I think everybody across the team, you know, sort of took it on board and has, you know, sort of really tried to progress and recognise that, you know, there's a lot more that we can do, and having this format, you know, sort of, you know, and highlighting all these are areas we need to improve has made us all think, well, you know, a bit like Trish's presentation, you know, sort of what actually can we do to think outside of the box, and how can we make it not only better for the women and the babies, but better for us as well, to improve, you know, sort of improve our working life. So embedding SCAPE into everyday practice, because it is such a big document, what we've done, you know, sort of to keep that momentum going, is we've actually split it out into smaller chunks. So all of our Band 7s and managers across the unit now, you know, sort of look after 2 areas, so that it doesn't feel like too much of a daunting task. And, you know, sort of when we've got Band 6s now who, you know, sort of fit in with areas of that, so it really becomes a team initiative to keep, you know, sort of keep us in the green for all these areas. And that's our journey. Thank you.
Welcome to my short but hopefully informative presentation on my Safer Everyday, with an emphasis on looking after ourselves to ensure that we can look after our service users, which fits very, very nicely in the whole regime of Safer Everyday and the whole ethos behind Safer Everyday with regards to demonstrating falling harm rates, so that we as individuals can eventually look after our service users. I chose my subject matter after considering quite a myriad of topics, due to a real life experience just recently, when a couple of months ago I was, perhaps like everybody else, driving of an evening time, getting dark, and I came across an individual who was walking in the road, and that individual only became apparent to me when they were level with the car. So things luckily turned out okay, but could have been a lot worse. And that individual in the dark and we've all seen it, was pretty much dressed like I'm dressed now. Yeah, we've all been there, haven't we? We've seen pedestrians, people on bikes with no lights, etc., etc., dark clothing. We don't give ourselves a fighting chance of avoiding some people, sometimes. So my presentation is on be seen, be safe, because we do owe it to ourselves and our service users. So why is it such a problem? Okay, the latest statistics I've been able to get from the police service in Guernsey at 2017, and there was just shy of 400 road traffic collisions in 2017, and those including pedestrians. 2 fatalities on our roads, which is too many. Lots and lots of serious incidents and minor incidents, and a myriad, I'm sure, of incidents that haven't been recorded. Within that, we could see that 2 pedestrians came into contact with vehicular traffic, and again, that is too many. So they're the statistics from Guernsey Police. So what's the problem, I hear you say? Nothing really to see there. If we can play it again, what I will highlight is, albeit the individuals on a bike, okay, roundabout, now is an individual on his left hand side there, all in dark clothing, wheeling a suitcase. We've absolutely no chance. Again, this is pretty much common sense. And there are 2 things that I want to concentrate specifically today. And that's about fluorescent and reflective clothing. Fluorescent means brightness, really, something like that. And I don't expect everybody of an evening to walk around in a high-vis jacket. But something like yellow and orange is reflective during the daytime. So this jacket here, the yellow is reflected during the daytime, and fluorescent during the daytime, and the reflective bits are the silver strips. And you may have seen, and I think it's an absolute fantastic invention, these types of jackets, which are reflective when headlights hit them. I mean, I didn't know about these till I came to Guernsey, and you see joggers, people on bikes, and they're absolute life-saving pieces of equipment, just a coat like that, and they're freely available throughout the island, and relatively cheap too. Not only that, I don't know if you've seen something with regards to these slap bands. Have we seen them? Okay, they're very, very cheap, and I'm doing my best to try and get some for our organisation. Certainly the community, and when we take our service users out in the community. And they're just slap bands, and they're absolutely fantastic in terms of being reflective during the day and during the night. They cost pennies, and I'm trying my best to get some. The ending gambit is something very, very topical that I saw in the Guernsey Press today, and that is Bright Day, all about being seen. And if I can read what today's press said, is Bright Day is back and Living Streets Guernsey is encouraging as many businesses as possible to take part in the Dress Down event this Friday. Bright Day happens just before the clocks go back, very topical, and the nights draw in, obviously. This is an annual event when we encourage pedestrians and cyclists to brighten up after dark. said the chairman. The limited street lighting means that Guernsey's roads can be lethal, particularly on dark, rainy nights when vehicle stopping distances are affected. Our message to all pedestrians and cyclists is please make sure you can be seen. Be safe, be seen. And it goes on to say, with regards to stopping distances in vehicular traffic are extended during dark, wet weather. So therefore, be extra vigilant. And the bottom line is, please try to be seen and be safe by using reflective, bright-coloured clothing during the dark hours, especially of an evening. So, although what I've presented on today is probably 99.9% common sense, it's a good, timely reminder to ourselves, especially if we're out in the community, and really especially if we're responsible for our service users during that time, to be seen, be safe. Thank you very much indeed for listening.